And I want to introduce our speaker today. It's Sarah Podwika, who is a first-year Gynecology Oncology Fellow at UVA. She's originally from Pennsylvania and attended the University of Notre Dame for undergraduate, where she majored in accounting. She completed her medical school and residency in OBGYN at the University of Virginia, and she's currently obtaining her master's in public health and will graduate in August of 2022. She's interested in the topic of abnormal placentation, as gynecological oncologists are part of the multidisciplinary team that cares for these patients. So without further ado, I will turn it over to you. Thank you.
Hi, everyone. Like Shannon said, my name's Sarah, and we'll be talking about abnormal placentation, but mostly placental accreta spectrum. And so we'll get going. Maybe if I can click on it. Okay, I have no disclosures. I will say that I am interested in this in residency. I worked on a paper with some of our MFMs looking at how we manage patients who have placenta accreta spectrum pathology and sort of what the outcomes are. And so I'll mention that here and there. So why does abnormal placentation matter? It matters because it's on the rise. So cases of abnormal placentation have been estimated currently to be between 1 out of 533 births to 1 out of 272 live births. And this is about an 8-fold increase since the 1970s and 1980s, when these numbers were also being tracked. Abnormal placentation can be associated with significant maternal morbidity and mortality, and this is often due to obstetric hemorrhage. And all the guidelines, ACOG, MFM, recommend delivery at level 3 or level 4 maternal care centers. And so that means they have a high level of subspecialty care and that they're able to provide access to blood banks, radiology, trauma surgery, things like that. And we'll talk about why that's important. Additionally, ACOG and MFM recommend using multidisciplinary teams to provide adequate surgical planning and management of these patients. So we'll sort of talk about the different terminology, some of the pathology, the risk factors, the diagnosis, the management, and then I didn't actually find much about counseling, but we'll sort of go into it at the end. So placenta accreta spectrum is the name of this group of abnormal placentation, and it was formerly referred to as morbidly adherent placentation. They've changed that now, and the new term is this PAS, placenta accreta spectrum. And so the spectrum of invasion goes from accreta to increta to percreta. And I'll show some pictures, but in general, normal developing placenta attaches to the endometrium, not into the myometrium. And so that when the baby is delivered, there's sort of a clear plane. Those of us who have delivered babies or been in at the delivery are able to recognize that you can, easily separate the uterus from the placenta at that sort of endometrial junction. A placenta accreta is the attachment of the placenta to the myometrium, but it doesn't go into the placenta doesn't go into the decidua. An increta is an invasion of the trophoblasts into the actual myometrium. And then a percreta is sort of a wide range. It basically means through the myometrium, into the uterine serosa, and into surrounding structures. And so here, this is a nice picture from the New England Journal of Medicine. And so this just shows sort of the gradation that we just discussed. So here you have a normal placenta. And you can see it's right up to the endometrium. There's no invasion. Here is the placenta accreta, and so it's through the endometrium, that normal layer of uterine tissue, but not into the myometrium. And in increta, you can see that you start to get invasion into the myometrium. And then in this depiction of a percreta, the placenta has entered through the myometrium into the serosa, but it can continue onwards. It's not uncommon to have expansion to the bladder, to parametrial tissues, which can make these surgeries quite complex. And so this is an example from our pathologists of a, well, I'd make people guess, but I can't see anyone. I'm guessing, which is a placenta accreta, because I don't think it's coming through the serosa here, but you can see there's no myometrium. There's just this thin layer of smooth serosa, and this sort of ugly ballooning thing is the placenta here. And so this was performed via cesarean hysterectomy at our institution. So abnormal placenta development was first described in a cohort of 18 patients back in 1937. This was by Drs. Irving and Hertig, and they noted that they found sort of a complete absence of a decidual basalis layer and an abnormal adherence of the placenta, sometimes in whole or in parts. And so that's sort of when we first start talking about placenta that's not really separating normally. And sort of the theories for why this happens, why that placenta doesn't stop at the endometrium, as we saw in that previous picture. It could be a defect in the trophoblasts. They're sort of the cells that go, if you remember, go into the endometrium, help change the spiral arteries and develop the vascular flow, allowing for sort of the attachment. You could also have a basalis defect due to a failure of normal sort of deciduization of the placenta. And then, as we'll discuss a little bit further, a lot of this has to do with areas of scar tissue. And so you can get abnormal vascularization and tissue oxygenation in the area of the scar tissue, which may cause some of the issues with placental remodeling and invasion into the wall as they're trying to develop additional blood supply. And so this is just sort of a quick little schematic from Gowdy obstetrics. And so you can see here, so this is the placenta here. Here's, the endometrium, myometrium, and then here's the blood flow. So these are the spiral arteries, and these are the normal cotyledons. Here you can see in an accreta, it's invading into the myometrium, just like we talked about in that other schematic, and it forms these lacuna, which we'll discuss further. But basically, due to the abnormal nature and invasion, you get these large vacuoles of blood-filled area, and we'll show a few other pictures of those as well. So the biggest risk factors to have this placenta accretive spectrum are having a prior cesarean delivery. Even if you have a normal placental location, if you've had a cesarean delivery, there is a risk of 0.3 up to sort of 6.7 if you've had more than 5 C-sections, which is becoming a little bit more increasingly common. And so that's sort of just standard base rate if you've had a C-section. The real problem becomes when you have a placenta previa. I'm not sure who's on today, but as a review, placenta previa is when the placenta covers the cervical os and is in the lower uterine segment. Patients are not able to have vaginal deliveries when that is the case. And so these are sort of common statistics that lots of OBGYNs learn, that if you have a prior cesarean and a placenta previa, you have a 3% risk of an accreta. If you've had 2 prior C-sections, that risk increases to 11%, 3 prior is 40%, and 4 prior is 61%. And so if your patients have had more C-sections and they also have a previa, there is a high chance that they might have a previa, and it's important to look. And that also is likely due to as we talked about, the rising incidence of this. And that's because we're doing more C-sections in general, as everyone knows. There have been some studies looking at if there's elevated placental biomarkers and if they are able to aid in the diagnosis or screening to rule out if it's actually an accreta. And unfortunately, none of the studies have proved favorable in terms of looking at biomarkers in maternal circulation and the presence of an accreta spectrum. Some other risk factors all sort of go along with the idea of a C-section, and that scar and that possible factors of poor vascularization and oxygenation. And so anything that causes damage to the endometrium can result in a higher risk of a adherent placenta. And that could be like a uterine curettage. There's a myomectomy in that scar. If they've had an ablation, which hopefully there aren't too many pregnant women who've had ablations, uterine artery embolization, our prolapse uterus, and manual removal of a placenta. Additionally, advanced maternal age, having sort of some abnormal adherent placenta in previous pregnancies, maybe not so much that it was called an placenta accreta spectrum, but perhaps it was a little more difficult to remove. You needed to remove some manually, maybe use a banjo curette at bedside, things like that. Increasing parity, and that's just sort of goes along with things we've already talked about. And then in vitro fertilization, of course, with abnormal A, placental location, and B, there can be additional scar tissue. One question in the chat was if prolapsed uterus would have any impact on this, and not to my knowledge in anything that I read. And that's because sort of the prolapsed uterus it's a failure in the external uterine musculature, causing the uterus to prolapse. And these risk factors are more sort of internal to the uterus and the endometrium and things like that. Not saying that you can't have both, but I did not find that that was an additional risk factor. And so keep the questions coming. All right. Sorry, next slide. So to diagnose these, ultrasound is the best. It's the best for all obstetric things as we know. And so you can start to identify this accreta spectrum as early as the first trimester. Unfortunately, most are diagnosed not unfortunately, but sometimes they're diagnosed in the third trimester, which can be a bit of a surprise, and often in the second trimester. As we mentioned, placenta previa is a large risk factor, and 80% of accreta spectrum cases have a placenta previa. So when performing an ultrasound, there's multiple features that you can look for, and so we'll sort of go over these. And one is those multiple vascular lacunae, and that's what I showed in that graphic where larger blood vessels have formed as it's I don't know what's the word I'm trying to say, invades into the myometrium. You lose this hypoechoic zone between the placenta and the myometrium, which is usually the endometrium that we talked about. And you can think of sort of regular ultrasounds, and the endometrium is hypoechoic. You get a decreased thickness of the retroplacental myometrium. So when you're doing an ultrasound, you might notice that the placenta is quite thick, and then you're not able to see much uterus over top, and it's usually less than 1 millimeter. When you are scanning, in addition to looking at the uterus, you usually look at sort of surrounding structures, and you can find sort of abnormalities of the uterine serosa, or even, usually there's a smooth plane between the uterus and the bladder, and that can have some abnormalities. And then, as we discussed, visual extension of the placenta to other organs. And the most common ones that we've encountered are the bladder, just given its location and near the lower uterine segment, and sort of the parametrial tissue. Additionally to just sort of your standard obstetrics ultrasound, you can also use the Doppler on the ultrasound. And so you'll see sort of this turbulent lacunar blood flow. So not only will there be these, large lacunar lakes, when you turn on the Doppler, you can see lots of turbulent blood flow. And then you'll also see vessels that can go from the placenta all the way to the edge of the uterus. And so that's sort of abnormal because usually you should have sort of distinct planes. In one paper I was reading, ultrasound has 90.7% sensitivity and 96.9% specificity for accreta spectrum diagnosis. This was a systematic review, and they know that there might be some bias in their numbers since they were reporting specifically on placenta accreta and the institution of where these ultrasounds are performed. If they're an institution that has more cases, usually their sensitivity and specificity are higher than if they're performed in locations that have fewer. Additionally, people sometimes jump to, well, let's use an MRI. And so MRIs are safe in pregnancy, as we know, and the sensitivity is great, usually at 94%, and the specificity drops a little bit of 84% compared to the ultrasound. when sort of to get an MRI, it's not needed for all cases of suspected abnormal placentation. It's good to use if you have a posterior placenta and the baby's in the way, you can't quite tell exactly how far it extends. And then why we use it a lot at UVA is to look at invasion for placenta accretas. What other, structures and tissues are involved? Is there anything else that we need to be planning for surgically? Do we need to get more surgeons involved? Things like that. So we don't recommend MRI as a first diagnosis tool in these placenta accreta spectrums. So this just shows, for those not familiar with ultrasound, so this is a transvaginal, here's the cervix, and then here you can see the placenta sort of laying over the cervix, which is placenta previa, and then these are the lacunae here. And then this is transabdominal, and then these large starred vacuoles are the lacuna. You can also, as we discussed, have a loss of the retroplacenta hypoechoic zone. And so here, again, transvaginal cervix, placenta previa, you have that bright, preserved hypoechoic zone, but here you can't really tell. So here again, here's the cervix, here's cervical loss, here's the placenta, but you've lost that bright line, showing that there's not quite that interface that you would expect, which would make separation difficult. You can also get hypervascularity, as we mentioned. So here you can see a lot of different vascularity happening when Doppler flow is turned on. Additionally, this is the bladder here. And you can see sort of this outpouching in towards the bladder, which is more suggestive of accreta. So once it's been diagnosed radiographically, what do you tell these patients? You obviously don't want them to go into labor because that can increase bleeding, especially if the patients have previous, and as we mentioned, about 80% do. And so, like everything in obstetrics, it's a balance between the neonatal risks of early delivery with the maternal risks of bleeding and emergency surgery. ACOG recommends delivery between 34 and 0 and 35 weeks, 6 days, if the patient is stable. You can deliver sooner if there's bleeding. If there's someone early bleeding, sometimes you can admit them and make sure everyone's aware of what's going on. Of course, maternal indications such as preeclampsia, other conditions. If the patient starts going into labor, you have to deliver them, rupture of membranes, or if there's sort of fetal compromise. And then it's important to note too that steroids should be given per standard practice. It doesn't affect anything to do with the placenta or the delivery. So it's important because of how complex these cases are with the increased vascular flow and the high risk of hemorrhage that there is an interdisciplinary team, and that's sort of why recommendations are to deliver at those larger tertiary or quaternary care areas. So the UVA team, we have one, and it includes maternal fetal medicine. They are the ones who follow the patient, of course, diagnose them, do a lot of the counseling, and then are the ones who perform the actual cesarean, do the hysterotomy, deliver the baby. And then we have Gynecologic Oncology. They take over, and they're the ones who perform the cesarean, hysterectomy, and any other indicated procedures. We have interventional radiology see all our patients as well, and we are lucky that we have a hybrid operating room in where we're able to have interventional radiology with a C-arm available while we operate. And then we have a strong obstetrics anesthesia interest in these cases. And so they're the ones providing the anesthesia. And then of course the pediatrics and NICU teams. But if needed, it's important to know that you can consult urology if concerned about ureters, things like that. So when you're doing the cesarean delivery, it's important to note that the placenta remains in situ. You don't even attempt to remove it, and hysterotomy is closed quickly. These cases can be performed under sort of a combined spinal epidural, regular epidural, general anesthesia, or it's possible to convert from an epidural to general anesthesia sort of after the baby's delivered if the mom wants to, see the baby and the anesthesia team is comfortable with that. And sort of just given the large blood loss, planned delivery is preferred over emergent delivery. And as I mentioned at the beginning, we were looking at a bunch of the cases that have been performed at UVA, And sort of before we moved to this interdisciplinary team, the average blood loss was 2.6 liters. Now it's about 1.6 liters, which is a great improvement. And so I think a lot of that also has to do with just planning, having the team and the resources available. So here you can see a picture of the uterus with this accreta, and you can see sort of the vessels, and it's through here to the serosa. There's no tissue left. These should be done with an incision that provides the best visualization. So usually that's midline vertical. Sometimes you can do other incisions if the provider's comfortable, like a Maillard or a Turney, but at UVA, we sort of standardly do a midline vertical for the best sort of operating field. And then depending on the placental location, usually it's in the lower uterine segment. So you would do a classical incision. You want to try and avoid disrupting the placenta as much as possible to reduce blood flow. So the placenta is left in situ, clamped, and then the hysterotomy is closed in sort of a running fashion to reduce blood loss. And then the hysterectomy is performed. Cesarean hysterectomies are often bloody with large vessels. You can use standard clamp cut tie. Often we use clamp cut tie and sort of the larger coagulation devices like an end-seal or ligature, the handheld ligature. It's important to try and locate the ureters and hug the uterus as much as possible. Some studies have advocated using stents, having urology place stents prior to surgery to identify the ureters, but there's been no actual advantage shown with that. And so it's not standard of care. It's sort of if the surgeons recommend it based on imaging or for their comfort. The use of interventional radiology is debated. It's a standard practice for the planned cases at UVA. As I mentioned, we have a hybrid operating room. And so there's, looking across the United States at different locations and resources, there's mixed evidence for reduced blood loss. As I said, UVA has found that it does reduce our blood loss. Often what's performed is there is arterial access gained either from arterial, and bilateral iliac artery balloons are placed preoperatively. And then after the baby is delivered, the balloons can be inflated during the hysterectomy. And unlike some of the IR techniques from long ago, these balloons, they're able to inflate and deflate. So they're able to sort of periodically provide blood flow via the iliacs to avoid ischemia for other parts of the body. And then they're able to remove these at the end of the case. So here's just a quick picture of what this is. So here, they've gotten femoral access, and you can see that they're running these balloon catheters into the common and then into the internal iliacs, which is where the uterines branch off, and same with the other way. And so here's just sort of radiographically what that looks like. And they're able to deploy these balloons in sort of a successive compressive feature. Usually it's about like 40 to 60 seconds of occlusion at a time, which helps reduce blood flow and can make for less morbidity for the moms. Some other surgical considerations is that many of these patients require ICU admission pending blood loss. As I discussed, it's not uncommon to lose close to 3 liters, if not more. And so whenever the surgeries are being performed, it's important to have frequent communication between the surgical team and anesthesia, and then frequent lab draws. They have point of care, if they can run blood glasses, things like that. And it's important, ACOG stresses that you need to have a well-supplied blood bank with multiple different products available. So if there's a patient who's sort of teetering and you think they need to be delivered, it's important to move to a place that has a well-supplied blood bank. Another important consideration prior to these surgeries is to maximize sort of the preoperative blood counts. And I'm not sure if this has been talked about, but so if they do have iron deficiency anemia, which is the most common, having iron every other day is the most beneficial to see an improvement in their counts. And if they start with higher counts, they hopefully receive less blood. And so there's maybe questions about, have you heard about conservative management, methotrexate use? I believe some universities in North Carolina were doing some studies with methotrexate use. What conservative management is you leave the placenta, you close the hysterotomy, and then you hope that the bleeding is not too bad and that the placenta will absorb and involute on its own. This can happen over many months. Often there's still significant bleeding, and so sometimes these patients require a uterine artery embolization sort of right after while they're still in the hospital. Additionally, the tissue may take a long time to absorb, and so sometimes there is the need to go back and remove this tissue hysteroscopically, and so, to try and prevent scarring, things like that. But as we've discussed, this is also a risk factor in terms of developing an abnormally adherent placenta in the future. There's also been some investigational studies looking at using focused ultrasound. And so that would be, if you leave the placenta in place, using focused ultrasound to help sort of destroy the placenta. Unfortunately, another time that the placenta might be left in situ and the hysterotomy is closed is if the patient delivers at a smaller institution that doesn't have all those resources that we've talked about. In that case, you can leave the placenta, close the hysterotomy, pack the patient, and ask for transport to a place where they can then have a hysterectomy. As we've discussed, the risk of having the placenta spectrum increases the number of prior C-sections, but those who want conservative management are often those patients who have had only, one previous baby or no previous children. And so that's when they might be more opt to try these conservative measures. Of course, there's always a risk of infection and things like that when the placenta is left in situ. So that's sort of all I have. That was about a half hour. I know some people joined late. I'm happy to talk about anything that people have. I will mention that I think these are some great resources. This placenta accreta spectrum, it's in the New England Journal of Medicine, and it's a review article from 2018. It's really useful. And then ACOG and SMFM have this obstetrical care consensus on placenta accreta spectrum that was also published in 2018. And those are really good resources sort of with whole comprehensive care and ways to go about imaging and discussing risk factors and everything like that.
Thank you very much, Sarah. I am realizing there was complications with our link today. So I had about 8 emails that they couldn't get in. So I don't know what that is about. So those that have joined by phone, thank you for trying the phone. I definitely want to let everybody know, though, today was recorded and is still being recorded. So we can definitely, I will get the link uploaded or the video uploaded to VNPC YouTube channel this afternoon, and we'll resend out that link so everybody can watch it, because I know this was a much anticipated presentation. So does anybody have questions? I know it's a little bit difficult, but if you are able to raise your hand next to your phone, I can give you permission to speak. I hate that allow to talk. I can unmute you from my end so you can talk, because I know chatting might not be the easiest to ask any questions. And again, I apologize for the inconvenience. Also, I'm sure, Sarah, it would be okay if after they listen to the video, if they have any questions, are you okay with them emailing you?
Sure.
Okay, so I will include her email address when I send the link out for any further questions. And I'm not seeing anybody with their hand raised. And nothing in the chat. So without further ado, thank you very much for this excellent presentation today. And like I said, I don't know why the link wasn't working, so I'm sure you will have some additional questions within the week. So Thank you everybody for your attendance and your perseverance to try to get through. But we will troubleshoot and figure it out for next month. So thank you very much.
Thanks for
Have a
having me.
good day.
Bye-bye.